Welcome to the Optimizing Care for Patients with IBD, highlights from the Advances in IBD Conference webinar series. I'm Kimberly Frederick, Senior Vice President of Mission for the Crohn's and Colitis Foundation of America. On behalf of CCFA, welcome everyone, and thank you for attending today's program, which is supported by an unrestricted educational grant by Centocor Ortho Biotech. This program is our first webcast series targeted to healthcare professionals, and we are very excited to offer this program as part of our commitment to furthering professional IBD education year-round. The content covered in today's program stems from the Crohn's and Colitis Foundation's 2010 Annual Advances in IBD Conference, which is the leading conference on Crohn's disease and ulcerative colitis. The 2011 conference will be held December 1st through the 3rd in Hollywood, Florida. For more information regarding the conference and registration, visit advancesinibd.com. It is now my pleasure to introduce Dr. Richard McDermott from Albany Medical Center, who will be moderating our program.
Good evening, and thank you, Kim. Welcome to tonight's webcast, the latest in genetics, risks, and therapy management in IBD, with our outstanding IBD faculty, Drs. Miguel Reguero, Corey Siegel, and Scott Snapper. My name is Richard McDermott, and I will be your moderator tonight. Following each presentation, we will open up the program to a short question and answer session. You can submit your questions then or at any time during the program via the web by typing in the Ask a Question text box and clicking the button to submit. We will take as many questions as time allows. You can collect your continued education credit after completing the evaluation form at the conclusion of this program. If you should need technical assistance, please type your inquiry into the tech support box on the left side of your screen and click the Send button. If you are disconnected from the webcast, you can log on again using the instructions provided to you for accessing this presentation. If you cannot log back on with these instructions, please call 877-843-9272 and ask for assistance from one of our technical support representatives. It is now my pleasure to turn the webcast over to our first speaker, Dr. Corey Siegel from the Dartmouth-Hitchcock Medical Center. Dr. Siegel will speak on communicating the risks of IBD therapy to our patients. Dr. Siegel, the floor is yours.
Thank you, Dr. McDermott. I find the hardest part of most patient interactions are those last few minutes in the office when you need to make a decision about therapy and then communicate the benefits versus the risks of those therapies to your patients. I find it an emotional time for most patients, particularly if parents are involved. And it's always hard to understand what our patients know and what our patients understand. So over the next few minutes, I hope to give you some tips on how to make this a little bit easier. The first part that makes this difficult is that medical literature is very confusing. The medical literature, which is published for us, is supposed to then be translated by us to our patients to make sense about the benefits versus risks of therapy. The data can be presented as small fractions, as standardized incidence ratios, relative risks, p-values, or even odds ratios. But I find that those really aren't helpful when talking to patients. It's much more helpful to try to make it more meaningful to them. You might think that words like rare and common make it easier. However, I'll tell you that those are very misleading. In a recent study we performed at Dartmouth, we actually asked patients what they thought about the word rare and what that meant regarding side effects. They gave us a range of answers starting from 2 per million up to 5%. So you can see how patients can be very confused by using these words that may mean very different things to different people. The next part is that numbers are very hard. The term is called numeracy, or quantitative literacy, which is really the aspect of how people understand small numbers. In one study, half of patients weren't able to convert 1% to 10 per thousand, and 80% of patients were unable to convert 1 in 1,000 to 0.1%. In the same study, it was found that patients had a very hard time determining what was higher, 1 in 27 versus 1 in 37. So think about the way you present data to patients. We use these sorts of terms all the time, and they can be very, very confusing. If you think, well, maybe it's the patients that are having trouble, it's really not the case. The same sorts of information were presented to medical students, and I'll tell my colleagues here that medical students really had just as much trouble with this information as the patients did in this study. The next part is that misleading patients can be very easy. This term is called framing. You might present data in different ways, hoping that patients take them in different manners. For instance, you might present the relative risk of something happening, specifically a relative risk reduction in this case of a heart attack of 34%. In the same study, they asked patients about the absolute risk reduction of 1.4% of heart attacks using a certain statin medication. You might agree that patients are almost always going to take that top medication choice, with a 34% reduction in heart attacks versus a small 1.4% reduction. However, as you may have figured out by now, both of these show exactly the same chance of a heart attack, decreasing from 4.1% to 2.7%. So again, this is the idea of framing, and we do this sometimes accidentally, but we have to think about this when we see data and we have the opportunity to present it to patients. Therefore, using absolute risk is usually the best way to clearly communicate this type of information to anybody you're talking with. Some tips for clear communication. First, less is more. We're always compelled to tell patients everything we know about the disease, about the benefits and the risks. The only good thing about Crohn's disease or ulcerative colitis being a chronic disease is that we get more time with patients to come back and get to know them, and they get to know us, and they understand their disease as we go. You don't necessarily need to tell them everything that very first visit. Absolute risks, as mentioned, are better than relative risks, which oftentimes can be very, very misleading. And avoid small decimals. Something like 0.06% sounds like a very small number, but so does 0.0006%, but these are on order of magnitude different. Also, try to keep common denominators. When talking about chances of things occurring, try to keep them out of 100, 1,000, or 10,000, as combining denominators and comparing one to another gets very, very difficult. Finally, give perspective to other life risks. We didn't talk about it here today, but driving to the office, if you look at the statistics, is probably one of the riskiest things our patients do as any part of their care. However, day-to-day risks that come into our lives don't really play into patients' decision-making unless you call it out and compare it to what we're asking with the medications. Finally, visual aids help, and I'll show you what I mean by this. This is essentially turning some of the numbers we have into pictures so that patients can understand. One example here is a very simple graph. You can see multiple different publications about side effects of 6-mercaptopurine or azathioprine, and here I show you a summary, which are probably the most important side effects that we want to communicate to patients. You see that we give rounded numbers, we're not showing small decimals, we're showing very simple words and numbers next to it so that patients can look at these and understand it, as opposed to trying to get confused with all the statistics that go behind it. A similar chart showing the risks of anti-TNF treatment. Now, when you're talking about these drugs, I always find it difficult as patients can get very caught up with the long list of side effects that go along with both of these medications. I try to call out the most important ones, specifically here the risk of serious infections, which is listed as 3% across the large clinical trials, and then non-Hodgkin's lymphoma. And I'll show you in a minute another way to look at lymphoma rate so that patients can get a better understanding of how small these risks really are when you think about the numbers and the data that are out there to represent them. This is what's called a risk palette, and here's how I represent risk to my patients. I show them this palette of 10,000 little patients that you might imagine are out and about to get treated with an anti-TNF therapy or a 6-MP or azathioprine. You have to call out the baseline risk of any of these issues. Any side effect that our patients might experience have some baseline risk. And here in the United States, the risk of developing non-Hodgkin's lymphoma is about 2 patients out of 10,000. You can see it's a very small number. Although the relative risk of developing non-Hodgkin's lymphoma on 6-mercaptopurine or azathioprine is about 2, really it's an absolute risk of only 2 increase out of 10,000. You can see it's still a very small number. And then finally, the risk has been estimated in a meta-analysis with combination therapy using immunomodulators and anti-TNF agents that the risk of non-Hodgkin's lymphoma is approximately 6 out of 10,000. So again, this is a way to represent absolute risk in a pictorial fashion so that you can avoid the difficult decimals of 0.06% or small numbers that are simply hard to understand. The last point I'll make is that patients, I believe, are willing to take risks if we present the data in a clear fashion. In this study, we asked almost 600 patients how often side effects occur and what willingness they would have to take side effects of certain things happening. For instance, here PML, progressive multifocal leukoencephalopathy described with the drug natalizumab, serious infections or lymphomas. As you can see, there were two really important trends here. One is that the sicker patients were, and the more benefit they might expect from therapy, the higher risks patients were willing to take. In fact, patients were almost willing to take a 1% risk of lymphoma occurring if they knew that they were sick and that the medications would work. The other point is that almost every single patient in this study was willing to take a risk higher than 1 out of 1,000. And out of all the risks I've shown you already today, most risks are lower than that. So if you're able to clearly describe risk to patients and make them understand the benefit they're getting from these drugs, my belief is that most patients are willing to take the risks as in belief that they're going to get the benefits that we expect from these medications. So in summary, communicating complex data clearly to patients can be very difficult, mostly because of the short period of time, but also because small numbers are difficult to work with. Try to simplify the message and present the information very fairly. Don't frame the data in the way that you want patients to hear it. Present data in the way that's fair so that they understand both sides of the argument. Communication tools can help improve patient comprehension, either similar to the ones I've shown you or other ones that I hope will be developed for all of us to use. And then finally, patients are willing to accept risk as long as there is measurable benefit. And we'll talk about that a little bit more today, but that's the key. If there's measurable benefit, make sure that your patients understand what they're getting, both sides of the argument of the benefit to risk equation. So thank you very much, Dr. McDermott, and I'll turn it back over to you.
We're now going to revisit the question that you in the audience were asked during the pre-webinar survey. When reporting data to patients about benefits and risks of therapy, typically the easiest format for patients to understand is 1. Relative risk, 2. Absolute risk, 3. Number needed to treat, 4. Descriptive words like rare and common, and 5. I'm not sure. Please enter your choice now. Currently, we have 70% of the responders leading the pack, but I'm not going to give it away as to what their choice is. And then 3 other choices are running about 12-15% range. So I think that we're bringing this to a conclusion. And the number one response is absolute risk at 62%. A few people said relative risk, a few people said descriptive words, and a few number needed to treat. Dr. Siegel, how do you feel about this answer that absolute risk is appropriate?
I'm thrilled with 62% of the answers. So absolute risk is the right response. This is actually a very well-developed field in risk communication, and multiple different ways have been attempted to understand what patients get most when you present it to them. And I keep saying patients, but it's really people and how you understand numbers. And absolute risk consistently seems to be the most easily understood across multiple different populations of patients, young and old. Relative risk, as mentioned, can be confusing. Number needed to treat is something that we use really as a statistical assessment and not a way to tell patients that you have to treat 30 patients. We have to treat 30 of you to get one of you better. And then, as mentioned, descriptive words like rare and common can be interpreted in so many different ways. So I favor absolute risk, and I think the data behind the field of risk communication would support that as well.
Dr. Siegel, you briefly discussed the fact that combination therapy, there is an increased risk of non-Hodgkin's lymphoma. Could you comment on infections for individual patients and the risk of combination therapy with regards to infections?
Yeah, sure. It's a really interesting topic, and we're learning more and more about this, I think, as we go on with large clinical trials. There are a lot of different ways to look at this, but it's somewhat reassuring in the large clinical trials. So, for instance, the SONIC trial, which I think we'll talk about a little bit more today, which was an assessment of using immunomodulator monotherapy and azathioprine or anti-TNF monotherapy and infliximab in this study. And the serious infection rate across both groups individually and combination therapy was just about the same. So although it's intuitive to think that using 2 drugs in combination might increase your risk of serious infections, we're simply not seeing that in the clinical trials. With one caveat, though, is that if steroids are thrown into the mix, it seems to be steroids in combination with any of these medications that does increase the risk of using all these.
You also mentioned benefit. How can you factor benefit into the risk explanation to the patients, particularly when you do not know if the patient's going to respond or not to the medication that you are presenting them with?
Right. I think that's the difficult question, and where really the art of this comes in choosing the patients carefully and who deserves and who gets these medications. And I think we have to think of a couple factors. One, does this patient in front of us represent the type of patient that was treated within the clinical trial? And if not, do we expect that the risk might be higher or lower? So, for instance, a newly diagnosed patient, we're seeing more and more that the response rates are higher than we've seen in some of the early clinical trials, versus somebody who has multiple fibrotic strictures, internal fistulas may have a lower response rate. So I think we have to individualize therapy based on the best clinical data that we have at the time.
Dr. Siegel, we have a question from Ryan O'Neill. Does the patient's age affect the way you communicate? For example, do you communicate differently to a pediatric patient as opposed to an adult? Do you communicate differently, and how is it accepted if you're speaking to the parents of a pediatric patient?
Sure. Well, let me take that question in 2 different parts with the 2 biggest risks that we think about with therapy. One are the risk of infections, and 2, the risk of lymphomas. So the risk of infections is definitely tied to the age of the patient. And if you look in the studies that describe serious infections, or even the very unfortunate circumstance of a patient dying from a serious infection, it's typically patients who are older than the age of 65, who have other comorbidities, also on steroids, possibly taking narcotics. Those are the ones who get into really big trouble with serious infections and the outcomes of serious infections. However, younger patients who aren't completely protected by this, we still have to tell them they're at risk, but the risk really isn't the same as somebody who's older with comorbidities and other medications on board.
That leads nicely into the second audience response question, and so we'd now like the audience to respond to question number 2. The risk of serious infections with anti-TNF treatment is approximately 3 per 10,000, 3 per 1,000, 3 per 100, 3 per 10, or number 5, I am not sure. Okay, our responses are coming in. Again, we have one of the answers that's far out ahead of 2 others. And in just a minute it will be finished. This is a question that is very important for all of us. Okay, half of the responders said 3 per 10,000, and a quarter said 3 per 1,000, and another quarter said 3 per 100. Dr. Siegel, your comments.
It's a little spread out here, so I apologize if I wasn't completely clear. The good news I have is that it's not 3 per 10. However, in the large clinical trials, it was about 3 per 100. So 3% of patients experience serious infections. It somewhat comes to how you define serious infections. And in most clinical trials, they're defined as infections that might bring you into the hospital requiring antibiotics. So again, we might rephrase this question in different ways to get different answers, but I think the number that's fair to communicate with patients would be that if you're starting one of these medications, either anti-TNF therapy, and immunomodulators are probably close, but this question is specifically on anti-TNF therapy, that the rate of serious infections is approximately 3 patients out of 100, or 3%.
Thank you very much, Dr. Siegel. Do you have any closing comments that you would like to make before we go on to our next distinguished speaker?
I think just the last comments are that we're still learning, and we need to be flexible with the way we speak to patients and with the uncertainty that we have about these data. So I always try to tell patients that today these are the best data that we have and the best information that we know, and to be open and honest if things change and as new information comes in.
Okay, well, thank you very much. We would now like to introduce as our next speaker Dr. Scott Snapper. Dr. Snapper is Director of the Center of Inflammatory Bowel Diseases at Children's Hospital in Boston. He's also Director of Inflammatory Bowel Disease Research at Brigham and Women's Hospital in Boston, and an associate professor of medicine at Harvard Medical School. Dr. Snapper is going to speak to us today about what the clinician needs to know about microbiology, genetics, and immunology in IBD. Dr. Snapper, the floor is yours.
Let me start by saying this is an incredibly exciting time to be a physician scientist studying inflammatory bowel disease, because every month we're learning more information that tells us more about the risk of inflammatory bowel disease as well as the potential for developing new therapies. So inflammatory bowel disease pathogenesis sort of sits at the middle of a genetic predisposition, an environmental trigger, which might be a luminal infection or some other environmental trigger. And together, these two things lead to a mucosal immune system abnormality. And that mucosal immune system abnormality leads to inflammation. So there's two parts to the mucosal immune system. There's the innate immune system, which is depicted on the left side of the slide, and the adaptive immune system, which is schematized on the right side of the slide. And the innate immune system is that part of the immune system that is there in the beginning. It doesn't change over time when someone or something gets exposed to toxins or dangerous substances. And so the innate immune system consists of the single epithelial cell lining of the intestine that separates the outside from the inside. The innate immune system is dendritic cells and neutrophils that sit underlying the epithelium and have the ability to take in foreign things and present those things to the adaptive immune system. The adaptive immune system is the cells that have the ability to respond and then adapt vigorously to a foreign substance or a foreign particle. And the adaptive immune system consists of T cells and B cells. So investigators for the last 10 years have been trying to figure out why one gets inflammatory bowel disease and thought that it must be an abnormality in either the innate immune system or the adaptive immune system. And most studies have focused on whether there were abnormalities initially in the adaptive immune system and specifically in T cells. The types of T cells there are in the body come in two varieties. One are effector T cells, which are the green types of cells on the left side, and regulatory T cells, which suppress or calm down the effector T cells, which are on the right side. And there are three types of effector T cells. There are Th1 cells, Th2 cells, and very recently, over the last several years, a third type, which are known as Th17 cells. Crohn's disease, for the longest time, had thought to be a disease that was a Th1-mediated disease because there was lots of interferon gamma and TNF. And ulcerative colitis was thought maybe to be due to a Th2 disease with increased amounts of IL-4 and IL-5. Most recently, it's now been found that Crohn's disease is likely a Th1 or Th17-mediated disease, and Th17 T cells are those cells that secrete IL-17. Well, I mentioned that there are these regulatory cells that suppress inflammation, and so many investigators thought that abnormalities in regulatory cells might be the reason that one gets ulcerative colitis or Crohn's disease. In fact, as of today, there is no strong data suggesting that abnormalities in regulatory cells is the primary defect. So what we know from studying the immune system now is that Crohn's disease is likely a Th1 or Th17-mediated disease with lots of interferon gamma, lots of TNF, and IL-17. And therapeutics have been developed that respond against those substances. And of course we know that because Remicade and the other anti-TNFs like Cimzia and Humira are against the TNF molecule. Ulcerative colitis, we're still not sure. There's some data suggesting that it's a Th2-mediated disease. And we know that regulatory cells can control inflammation, but they don't seem to have the primary role. So that's the basics of the immunology of inflammatory bowel disease. But we've learned a ton by studying genetics. And we've known that inflammatory bowel disease had a genetic component for quite some time because twins when one studying twin pairs, there was always an increased risk of one twin getting IBD compared to the second. The first gene that was identified that was clearly associated with inflammatory bowel disease was a gene that is called NOD2. NOD2 only accounts for a minority of risk for inflammatory bowel disease, but really led to a sea change of our understanding, because NOD2 is not a gene that aids in the adaptive immune system, but actually appears to be a gene that is important for regulating the innate immune system. And in particular, NOD2 has taught us, or NOD2 is important for recognizing intracellular bacteria. So bacteria clearly have a very important role in the pathogenesis of inflammatory bowel disease. That, of course, was not that surprising, because we've known for a long time that antibiotics against bacteria can be helpful in certain types of Crohn's, in particular Crohn's colitis. Well, after the first gene was discovered, a number of investigators throughout the world were looking for a number of other genes, and using a variety of different techniques, including something called genome-wide association studies, they found out that actually there were many genes that controlled innate immune function that were important for risk for inflammatory bowel disease, including some genes that regulate a process called autophagy or autophagy, which is the process that cells conserve energy and eat themselves, or in addition, it's the process where a cell regulates internal bacteria by taking it up. Many years later, after the initial discovery in 2001, more than 50 genes were discovered. So by 2008, there have been 50 genes that have been discovered, shown to have increased risk of inflammatory bowel disease. And some of those genes regulate the process called the adaptive immune system, which I just spoke about. In 2011, now, there are almost 100 genes that have been associated with the increased risk of ulcerative colitis or Crohn's disease. Interestingly, all of those genes together probably only account for just less than the majority of cases of IBD, suggesting that there's still a lot more information to be learned. In studying all of those genes, what have we learned? Well, we've learned that for Crohn's disease, there are genes that affect the innate immune system, in particular handling of bacteria and the process of autophagy. For Crohn's disease, there are genes that regulate the immune system. For ulcerative colitis, there are genes that regulate a process called epithelial barrier function, or the important function that the single layer epithelial has in the cell. I think one very interesting thing is that there's a whole slew of genes that is in the middle of those two circles that show increased risk for both ulcerative colitis and Crohn's disease. And those genes include genes that regulate the adaptive immune system, as well as other components of the immune system. So when we study those 100 genes, what have we learned? Well, we've learned that there are about 4 or 5 pathways that are critical for increasing risk to inflammatory bowel disease. One, as I mentioned, was the NOD2 gene, which is important in recognizing intracellular bacteria. The second, in the middle, is genes that regulate the process of autophagy. The third are genes that regulate the Th17 pathway, which is something that we had already known about from just studying the immunology. The fourth are genes that regulate epithelial barrier, and the fifth are genes that are important for the anti-inflammatory process. So finally, I'd like to talk about the critical importance of the human microbiome. The intestine houses 10 to the 14th organisms in the body. Most of those organisms are found in the distal ileum as well as in the colon, and they come in all sorts of varieties. Interestingly, less than half of those organisms have actually been identified, and less than half of those organisms are culturable. Importantly, the number of bacteria in the intestine is actually 10 times the number of human cells in the body. a number of investigators have been trying to figure out, well, what is normal? What is the normal human microbiome? And one of the ways that they've done that is by looking in twins and looking in the microbiome in identical twins versus the microbiome in fraternal twins. And it turns out that genetics might not be the most important thing that determines what your microbiome is, but maybe, in fact, might be the environment. Well, a big question related to inflammatory bowel disease is, can one change the microbiome? Can you change the microbiome? It's been thought that inflammatory bowel disease might result from a dysbiosis or a change in the number of good bacteria or bad bacteria. Studies by Jeff Gordon's group showed very interestingly that patients who are obese have a different microbiome than patients who are thin. And in fact, animals that are obese have a different microbiome than animals that are thin. And those organisms, there are two classes of organisms that are reduced in that particular situation. One of the most interesting things from Jeff Gordon's study was that patients that were put on a lean diet and lost weight were able to change their microbiome. Well, what does this have to do with inflammatory bowel disease? There have been studies by a number of investigators, including Frank et al. And others, that have shown that in inflammatory bowel disease, there are also changes in the microbiome. There are decreases in two large classes of microorganisms in patients with inflammatory bowel disease. And of course, one major question is, are those changes, do they lead to the disease, or are they a result of the disease? Finally, I've told you about genetics and genetic associations with inflammatory bowel disease, and I've told you about the importance of the microbiome in inflammatory bowel disease. Well, one of the most remarkable studies in the last year came out by Skip Virgin and Thad Stappenbeck at Washington University, which showed actually that a virus may be critically important for the development of changes in the intestine in the setting of an abnormal gene, such as one of the autophagy genes, and the presence of bacteria. So the study showed that not only do you need bacteria, but you also need the genetic mutation and you need a virus to lead to the changes. And so that has led many investigators to ask the question, it might not all be about the microbiome, it might not all be about genetics, but it also might have that viruses may have an important role. Finally, I'll summarize. Our knowledge today is that genetics is critically important. There are over 100 genes that have been identified that increase the risk of inflammatory bowel disease. The immune system is critically important, and it turns out that Th17 cells may be important for Crohn's disease. And finally, the microbiome, which includes bacteria as well as viruses, is likely to have a critical role in either the development of inflammatory bowel disease or the maintenance of inflammatory bowel disease. Thank you very much.
Thank you very much, Dr. Snapper, for that excellent presentation on the role of genetics, the immune response, and bacteria in causing inflammatory bowel disease. We'll now go to the audience response question. And the question is, we have learned that the genes found to be associated with an increased risk of acquiring IBD fall into each of the following pathways except. So which pathway did you not hear about? Innate immunity, adaptive immunity, epithelial barrier function, autophagy, or the Th2 cytokine pathways. And we have one leading area, which many people felt was not mentioned by Dr. Snapper. And so I think that we have a very good answer coming. And it looks like we'll be at about 53% for the Th2 cytokine pathways, which Dr. Snapper did not mention, but he did discuss innate adaptive immunity, epithelial barrier function, and autophagy. Any comments on that, Dr. Snapper? The
You know,
excellent answer by the audience, which I think is very good.
I'm impressed that the audience, the overwhelming majority chose Th2 pathways, and in fact, the audience is right that all of the other pathways have been shown by genetics to be associated with inflammatory bowel disease. Th2 pathways were initially suggested by immunology to maybe be associated with ulcerative colitis, although that data has not shown in genetic studies which are identifying genes that are associated with IBD.
Thank you very much, Dr. Snapper. Can you comment on this tremendous barrage of information that we're learning? How is that going to translate into therapies, a practical therapy? Is it going to be breakthroughs in genetics, breakthroughs in bacteria, breakthroughs in immunology?
You know, that's a wonderful question, Rick, and I think that what we're learning is that IBD, or inflammatory bowel disease, is not a single disease and is likely to be numerous diseases, and certainly with 100 genes already that have been shown to increase the risk of IBD, it's clear that IBD is caused by a number of different genes. I think that what we're learning from what I told you is that there are numerous pathways in particular that are associated with both Crohn's and ulcerative colitis. And what is likely going to happen is we're going to be able to target therapies specifically for one or the other pathway in particular patients that have mutations associated with that pathway. So, for example, if there is someone who has a problem with handling bacteria, we may come up with therapies that increase our ability to handle bacteria. If there's a problem with an overly aggressive adaptive immune system, we'll target therapies that suppress that. If there are problems with the epithelial barrier, we'll have therapies that improve the epithelial barrier. So I think that all of this knowledge will allow us to have targeted therapies for specific patients.
We'd like to now include some of our other panelists on questions in this very important area of basic science. First, Dr. Siegel, we've heard a little bit about genetics. How do you speak with patients regarding risks of developing IBD in children or brothers, sisters, etc., with regards to genetic risks?
It's a really important question, and I think we're learning so much about this. And sometimes the science evolves a little too quickly for use in clinical practice. So there are a number of companies out there, for instance, that you can order genetic testing for your patients to screen them for the risk of developing a disease. And, I'll see if my colleagues disagree with me. I don't think, though, we're at a point yet of using these tests that are available in practical circumstances to help understand what the risks are for our patients. For instance, NOD2, which is the most important gene, is very prevalent in society. By testing patients to see if they have it doesn't tell us they're going to get the disease. So I think sometimes it rings some alarm bells before we actually understand what to do with these results. So I talk to patients in many of the same ways I've talked to them before we had all this genetic testing available, really thinking about their family history, who they have had preceding them who's developed inflammatory bowel disease, and think about individual risks.
So you will go more on family history than genetic testing at this moment?
At this point I do. I always address the fact that genetic testing is available and that we're going to learn tremendous about this in the future. But in my practice, at least, I'm not using genetic testing to help risk stratify patients.
Dr. Aguero, how do you counsel your patients regarding risk? I think where this comes up most often is in children. As we take care of patients, everybody's concerned that their child, and we have some patients who do not want to have children because they state they do not want to pass the disease on to one of their children.
Right. I think this is an incredibly important and emotional topic, as the two of you have already alluded to. Probably one of the most common questions are, Mom or Dad has Crohn's or colitis, what's the chance of my offspring having that? Based on the current data, it's about 5% chance, to get to Corey's, hopefully I'm using the absolute terms correctly, 5% chance that one of the offspring will have it. If both parents have it, it's about 20%. I think the holy grail for all of this, and Scott, to your point, is that someday we'll have an individualized, personalized approach to treatment, and we will be able to do testing on patients, whether it be genetic, microbiome, by which we can guide our therapy. We're not there yet, but we're on the precipice. For parents, I tell them, go ahead and have children, let them eat the dirt, let them be dirty, and I'm joking about that, but maybe from an innate immune standpoint, being too clean is also unhealthy. So I think there's great hope. It's about a 5% chance that one of the offspring would have IBD.
Thank you very much, Dr. Snapper. Excellent presentation. Thank you to our panelists. We will now move on to our third presentation, which will be given by Dr. Miguel Reguero. This is a very controversial area because the issue is, can we stop or discontinue medications in our patients when they're working? And so Miguel Reguero, who is Associate Professor of Medicine and Associate Chief and Co-Director of the IBD Center, will discuss when is it appropriate to discontinue thiopurines, methotrexate, and biologics. Dr. Reguero.
Thanks, Dr. McDermott. I think this is probably one of the most common questions we're asked in our clinic. Patients doing well on 6-MPA-azathioprine, methotrexate, one of the anti-TNFs. Can we stop the treatment? All of us get this every day in our clinics. All of the healthcare providers listening tonight, this is probably one of the most common questions. My short answer is, from personal experience, that most patients doing well in remission, if they stop treatment, the probability of returning to their disease state prior to treatment is quite high. The question, though, is what is the evidence base and what are the evidence-based data to support this? This is an incredibly hot topic, and as Dr. McDermott already alluded to, we have very limited data. This is a table that we put together looking at the potential risk of relapse after stopping treatment. Rather than present 50 slides following this, these are the summary slides for stopping 6-MP and azathioprine in Crohn's disease. If you look at the left-hand column, there are 3 randomized controlled trials and 2 open-label trials. The second trial looks at how the patients were doing prior to stopping. So in 2 of the studies, patients were in remission for at least 6 months on azathioprine or in remission for at least 3.5 years on azathioprine prior to stopping. So these are the patients you see in your clinics that come in complete remission who ask, can I stop my 6-MP or azathioprine? The next column, 6-MP and azathioprine stopped compared to placebo. So these studies all looked at what happened in that year, in that 5 years after stopping treatment. Some of them randomized to placebo, some just stopped completely. And the final answer is on the right-hand side, and it's in the green bar. So these are the relapse rates. Look down that column. Patients in remission on azathioprine in the first study that stopped and were randomized to placebo, 41% of those patients recurred. There's a high rate of placebo response, up to 93%, up to 85% in the 6-MP study. The fourth study is the lowest at 21%, but nearly 2/3 in the final study had a relapse. What does this mean? This means that there's an incredibly high relapse on stopping 6-MP azathioprine, and all of the data suggests that it's statistically significant compared to those that continue treatment. What about ulcerative colitis? We don't talk about 6-MP and azathioprine much in ulcerative colitis, but there are actually good data, and it looks very similar to what we've seen with Crohn's disease. Again, on this slide, if you look on the left-hand side under the study, 1 randomized controlled trial, 3 retrospective reviews. The second column, again, very similar. Patients were in remission from their ulcerative colitis for at least 3 months in the last 2 and at least 6 months in the first 2 on azathioprine or 6-MP. The third column, then the patients were stopped in treatment or they were switched to placebo and were followed for a year and up to 5 years. What do you see? You see essentially the same thing. Relapse rates were quite high. In the first study, those switched to placebo, 61% relapse. In the second study, by 5 years, 3/4 relapse. In the third study, 6-MP, if you stop the 6-MP, up to 77% relapse. And again, 2/3 of the patients in the last study relapse. So very high relapse rates, again statistically significantly higher compared to those that continued on azathioprine or 6-MP. How would I put this in practical senses for the healthcare providers out there, for all of us in the audience here? I think the numbers needed to remember are the following. Relapse is common after stopping azathioprine and 6-MP. The best data we have right now suggests that about 1 year after stopping 6-MP and azathioprine, about 50% of the patients will relapse. For the patients coming into the office and say, I'm doing great on my 6-MP or azathioprine, what's the 5-year relapse rate if I were to stop? It's about 75%. So the conclusion from all of these studies and the discussion parts of all of these studies, the recommendation by the authors were for IBD patients in remission on 6-MP and azathioprine, continue treatment because the relapse rates are high. Well, let's shift gears now to probably even more of a hot topic on do we stop anti-TNF? I know you guys get this all the time. We were talking about this earlier. What happens in patients stopping anti-TNF? So we're seeing more and more of these patients in a very deep remission. There have been 4 studies, and again, these are somewhat small. Not all of them are randomized controlled studies. Actually, most of them are open label. But if you scan across the top, the second line, the blue line, the open label study, this is probably the one we talk about the most. This will probably come up at our national meeting again in a couple of weeks. This looked at 115 patients who are in remission on infliximab and azathioprine and had been in remission for at least a year. They then stopped the infliximab, continued the azathioprine, and look all the way to the right. 40% of the patients within a year of stopping the infliximab relapsed. Those that were restarted on infliximab actually were able to regain response. What about the second study? This looked at 354 patients in remission on infliximab. 48% of those patients stopped infliximab and then were followed up to 7 years. There were a majority on concomitant immunomodulators, but not all. Look at the relapse rates in this study. At 1 year, 50% relapsed. By 7 years, nearly 2/3 of the patients relapsed off of the infliximab. The third study shows very similar results. The fourth study is our post-op study in which people are in a complete or the deepest remission, meaning their disease was essentially cut out. They had no recurrence at a year on infliximab. 5 of our patients elected to stop the infliximab because they didn't want to continue treatment. What happened in those 5, and these are unpublished data, all 5 had a relapse of their disease, and in fact, 2 of the patients went on to require another surgery. So very high rates of relapse, and the numbers to remember in stopping infliximab are very similar to what we see in 6-MP and azathioprine. About 50% relapse rate at 1 year, about 3/4 at 5 years. Again, these are the numbers that I give my patients when I'm seeing them talking about the risk of relapse. I realize the data is somewhat limited, but at date, at least the trends seem to be about the same. Well, can we predict who will relapse off of medications? And this has been a whole area of interest in research to say, well, maybe we can come up with predictors of who's going to relapse and who will do well. Without going through this in too much data, stopping azathioprine and 6-MP and Crohn's disease, if a patient had signs of inflammation, there was more likely that they were going to relapse. Very intuitive, but there are data to support this. Similarly with ulcerative colitis, if a patient's clinically doing well on azathioprine 6-MP, but they have extensive disease, their disease was not in remission for very long, they weren't on a 5-ASA, or they had endoscopic evidence of inflammation, high rates of relapse. Same with rheumatoid arthritis, and then finally infliximab stop in IBD. It's an intuitive, we now know, but patients who feel well, who have endoscopic evidence of active inflammation, that's the patient that probably will relapse when the treatment is stopped. If they have an elevated CRP, interestingly, there's more and more on trough levels of infliximab. Patients who were shown to be in remission because their trough level was adequate, meaning the medicine was working, high rates of relapse. And then we know from the post-op data, the highest risk patients for relapse are the ones who will often recur. Corey already mentioned this earlier. We have to weigh the risks and benefits of long-term treatment. Yes, these are medicines, the immunomodulators and 3 anti-TNFs that are associated with real, albeit small, risk for serious adverse events. We do need to counsel our patients, as Corey already alluded to, on risk benefits. Interestingly, most of the adverse events, not all, but most of the adverse events we'll see within the first year to 2 years. Again, we can see longer adverse events, but if a patient's done well for a long period of time, at least there's a trend that seems to be occurring where patients do well. What are the 2 most common or most concerning adverse events, albeit rare, are infection and malignancy. And like anything, and Dr. Siegel already mentioned, we have to weigh the risks and benefits of treatment. So in my practice, now we're getting away from evidence because we have fairly limited evidence, I don't routinely stop biologic treatment in my IBD patients. However, if there is a circumstance, not a side effect, but a circumstance by which we need to stop treatment, I'd like to see a deep remission. And you'll hear this term repeatedly. Not only does the patient feel well, but there's no evidence of endoscopic inflammation. Also, that they've been on long-standing treatment. This isn't a remission of 2 months and you're stopping treatment. And that there's a second agent on board. I think there are emerging data to support concomitant immunomodulators, and if an anti-TNF had to be stopped, you'd like some other agent. And then finally, a plan B. If you stop that treatment, can you go back to that anti-TNF? There are going to be data presented at DDW showing that we may be able to restart some of these patients on the same anti-TNF, and if we can't, switching treatment is reasonable. So in my summary, stopping 6-MP, azathioprine, infliximab, and this would probably also apply to adalimumab and certolizumab, although the data are more limited at this point, are associated with high risks of relapse. Thumbnail numbers to remember, approximately half of the patients at 1 year will relapse if they're in remission off these treatment, approximately 75% at 5 years. But what's the most interesting, and from what Dr. Snapper was talking, I think this is going to be the crux of our future. About 20% of the patients can stop treatment, and they do well. Is it something immunologic, genetic? Is there a change in the microbiome? We don't know. And I think until we have better predictors of who will relapse off of these treatment, for right now, my practical answer is that we should continue treatment and maintain these patients in remission. So, Dr. McDermott, thank you for that allowance of introduction.
Thank you very much, Dr. Reguero, for your excellent presentation. We're now going to discuss the clinical cases and have our audience answer the questions that you raised. So the first audience response question is, a 42-year-old male with Crohn's involving the ileum and most of the colon is feeling very well on infliximab for the past 5 years. Previously, the patient had been treated with 5-ASA products and steroids before beginning infliximab. After being put on infliximab, he was also on 6-MP, but 2 years later, the 6-MP was discontinued. While on the combination therapy, the CRP, which had been elevated, went to normal, and the colonoscopy was excellent, demonstrating good mucosal healing. Now, 3 years after stopping the 6-MP, he remains asymptomatic, but the colonoscopy shows mild inflammation in the ileum and the colon, and also the CRP is now once again elevated. So the question is, the patient wants to stop the infliximab. Would you recommend 1, do not stop the infliximab, add back the 6-MP, 2, stop the infliximab, 3, stop the infliximab, and then restart the 6-MP? And so our answers are coming in. We have a lead answer by far, which is number, I can't give it away until we get all the final count here, but it's very clear that our audience would like to keep the patient on the infliximab because even though the patient's asymptomatic, there is evidence of inflammation, and add back the 6-MP. Could you comment on that, Dr. Reguero?
Yeah, I think that's very reasonable. I'm happy my audience response was so high. That's comforting. I think one of the aspects we didn't address is mucosal healing. I think we've all alluded to that in some construct, but this is an important case in a patient who clinically feels well. They have clinically silent disease, but mucosally and by parameters of a CRP, they have inflammation. I would certainly not stop treatment, and probably in this patient who had done well on combination, adding back the 6-MP makes the most sense. So I think that's a very reasonable answer. I would do that in my practice. I know, Corey, you alluded to some of the risk and benefit, but this is a patient that if they have smoldering inflammation for a long period of time, we all know now that the higher rates of surgery, potentially cancer, quality of life issues, hospitalizations, and they had done well. So we have a backdrop for that. I don't know what you guys think.
Well, I want to ask you a question. Is there a danger in stopping? if we understand that 3/4 of the patients will relapse, is there a danger, do we know if there's a danger, that if you stop the medication, they actually subsequently won't respond to reinitiation of the medication?
Right. So you're asking a very good, somewhat different question, meaning that if you have an anti-TNF and you stop it, can you restart it? And there are going to be some data coming out at DDW looking at stopping and starting the same anti-TNF. And the bottom line, without giving away all the answers, is you can do that. However, I think, in alluding to the immunobiologics of this, there is a tolerance and a more rapid clearance through the reticuloendothelial system that can occur in some patients, that maybe we see less of a response to the second agent, the third agent, or going back to the first. But I would certainly try that same medicine again. I don't know if you have a different feeling, Corey.
No, I think that's right. You quickly brought up a really interesting topic, which we haven't talked about, of mucosal healing. And, this is a common clinical scenario where our patients are feeling well, yet you perform a colonoscopy for one of a number of reasons, perhaps surveillance for colon cancer, and you notice that they still have active inflammation. Are you adding medications at that point to a patient who feels well? And this is something that's really another one of our hot areas of research right now. And I think we're starting to understand that mucosal healing is important, and that if we want to do the very best for our patients long term, that we need to get all of the active inflammation quiet, not just their clinical symptoms.
And we've learned this from the rheumatologists with rheumatoid arthritis. Right. 10 years ago, we were following clinical symptoms, but we know now that clinically silent disease is probably more common. Whether or not in 10 years we're going to follow histologic changes, there are emerging data on that in cancer risk and UC. I don't think we're there yet, and I would say that the audience is probably still split whether they follow clinical or mucosal, but I think that's a good point.
Thank you very much. We're now going to go on to the last audience response question. 42-year-old male with Crohn's involving 30 centimeters of the ileum and most of the colon, who's in clinical remission on infliximab for 5 years. Infliximab and 6-MP have been started at the diagnosis of Crohn's. The patients had a normal CRP levels. Colonoscopy 1 and 5 years after infliximab started revealed complete mucosal healing. The patient maintained 6-MP 75 milligrams a day since infliximab was started. This patient asked to stop both the infliximab and the 6-MP. What would you recommend? Number 1, do not stop infliximab or 6-MP. Number 2, stop them both because the patient's in deep remission. Number 3, stop infliximab only if the patient continues the 6-MP. Okay, our answers are coming in, and I think everyone paid very good attention to Dr. Ribeiro's talk. So there's a tie. Oh. And the tie, so this is great, a tie between number 1 and 3, that there are two options. That you could stop the infliximab and continue the 6-MP, which is basically the bridge therapy as done in the Gert de Haan's step-up, top-down trial. Or the second leading answer is do not stop either and keep the patient on both.
So I think Scott alluded to this in the last question. Can we stop the infliximab with 6-MP? So the honest answer to this is we have no idea. We don't know what the right answer is at this point. I think, honestly, until we have more data, you could go either way. However, one caveat. In a patient like this who had a sonic approach, as Corey alluded to the sonic study earlier, starting 2 treatments rather than one or the other, and looking at the data on withdrawing treatment, there's a high likelihood this patient will relapse within a 5-year period. Okay. Whether or not we can restart, we don't know. I would go with choice 1.
Thank you very much. We'd like to try to very quick answers now. Dr. Siegel, is there any relationship in a dose-response way between using 6-MP, azathioprine, and non-Hodgkin's lymphoma?
There doesn't seem to be. We don't understand exactly why patients get non-Hodgkin's lymphoma with these drugs.
So lowering the dose won't help prevent it?
At least we don't know that does
Dr.
help.
Snapper, what about stem cell therapy?
I think we're still a ways away from stem cell therapy. There may be certain conditions where people have a very, very strong genetic risk of getting inflammatory bowel disease, such as the IL-10 receptor mutation. But right now, stem cell therapy is a long way away from practice.
Okay. Topic of our next webinar. I want to thank very much our three distinguished panelists, Dr. Reguero, Dr. Snapper, Dr. Siegel, for doing such an outstanding job. And thank you for the audience for participating today. We hope you found that this webcast presentation was informative. After the conclusion of tonight's webinar, please stay on the line and you will be automatically redirected to an online evaluation form. After completing the evaluation form, information regarding how to obtain continuing education credit for attending this webcast will be provided. The archived webcast for the webinar series will be available in mid-May. All participants will be notified by email when this is available. Thank you again and good night.